profesorka klinické psychologie na univerzitě v Leidenu, kde pracuje jako vyučující, jako výzkumnice i jako terapeutka. Je jednou z předních světových odbornic na zpětnou vazbu o průběhu psychoterapie a je také předsedkyní a zakládající členkou toho, co jsme do češtiny přeložili jako mezinárodní síť podporující inovace a výzkum efektivity v psychoterapii. V roce 2018 získala cenu za vynikající výzkumné výsledky, výsledky mladých výzkumníků, kterou každý rok uděluje Společnost pro výzkum psychoterapie, SPR. Takže Kim, vítám tě tady a máš slovo.
Okay, so thank you for inviting me. I learned to say good morning in Czech, so dobré ráno, if it's correct. Yeah, I hope to tell you today a bit more about feedback, and I will give you kind of a general introduction to feedback as an overview of the research literature in this field. I was excited to hear that your department is also working on things like speech recognition and machine learning. This is something that I am also working on, and also analyzing like voice variations in the voice of the therapist, for instance, as a way to see if a therapist is more experiencing more emotions. That is all things that I won't be talking about today, but I'm excited to hear that that is research that is going on as well in the Czech Republic. Okay, but today we'll be focusing on routine outcome monitoring in psychotherapy. I guess I didn't change this little tiny detail of it being still in Italy. I did actually update the rest of my sheets, but sorry for that. Sometimes we do recycle our talks a little bit. Okay, so let's talk about what is routine outcome monitoring. I don't know how much background you have in this area, but I will just start with the basics. And I am sure the organizers can tell me when there is our questions or when I'm going too fast, or too slow. What is routine outcome monitoring? So basically, what we know is that research has shown that psychological treatments typically are relatively successful. About 2/3 of patients improve reliably in clinical research. So if we look at scientific research, we see that on average, about 2/3 of the patients improve reliably. But when we're looking in clinical practice, the results are less optimistic. So what we see is that only about 35% improves reliably, and that the effect sizes are about half of what the effect sizes are that have been found in research. So there is something going on in clinical practice that makes the therapies less effective. Well, we can of course come up with a whole bunch of reasons, like, you know, the selectiveness of patients into clinical trial, like inclusion criteria. Even if we look at that, there have been studies that have used data from practice and only selected those that have the same inclusion criteria. It's still less effective in real practice than in research. Now, one of the things, of course, that is done in research is that there's a lot of focus and attention on the treatment when we are treating patients. So, you know, the therapists know that they're being monitored, etc. And so one of the things that came up in the international literature is that monitoring patients' progress using standardized instruments might actually be a good way of sort of keeping the therapist alert when a patient might not be progressing well. And so a lot of scholars like Alan Kasdien, Bruce Wampold, Len Bigman have been recommending monitoring patients' progress as part of routine practice as a way to enhance the outcomes of routine practice. Okay, now let's have a look at outcome measurement. So normally in most studies, you would see the pre and post-treatment scores. And of course, if you only have 2 data points, you can only draw like a straight line between them. But does this tell us anything about the treatment? Not a lot, because we know that this is looks like a fairly successful treatment, but this is one of my own patients, by the way, and this was a person that I treated when I was working in the United States. And for the OQ in the United States, the cutoff for normal functioning is 63. So this was a patient with relatively mild symptoms who came in for booster sessions because she was worried she was getting more depressed. And so I offered her booster sessions to reactivate what she had learned in her previous treatment and kind of to help her, empower her to use the tools that she already learned in the earlier treatment. So I saw her every 3 weeks. And then if you look at this, it looks like, well, that's like a, seems like a effective treatment. Now, what we did in that clinic is we also used the BDI to measure the symptoms of the client for the depressive symptoms for each session. And this is how that looked. Now, this is a completely different picture. If you look at this picture, you think, what was going on compared to this picture where it just looks like, oh, this seems like a fairly successful treatment. In this case, actually, the patient was on antidepressant medication in the winter break. She visited her family. She ran out of her prescription, went cold turkey off the antidepressant medication, and then had a huge increase in depressive symptoms, which was ultimately then, when she got back on her antidepressant medications. We raised the frequency of the sessions to every week. And so we really worked hard to sort of get those more severe depressive symptoms down. But what it really showed, because I used the instrument, was that I could really see, even though her symptoms were going down, that at session 8, she was not doing better than she was doing at the start of the treatment, which I think is very hard if you just use your clinical judgment to determine that, to kind of still see how was it at the beginning. And what I also saw that was over the next sessions, that actually each session, her symptoms were going up a little bit, like they were not decreasing anymore. And so it was actually moving in the wrong direction. And that's also very difficult to see with clinical judgment. If, what's the difference between a score of 14 on the BDI and a score of 16 on the BDI? That's 2 points. It's like a tiny increase in the degree of depressiveness, so to say. But, with the trend of having multiple measurements, you can still clearly see that there was like an increase in the symptoms. And so I really as a therapist, use these measurements to help me sort of notice that the therapy was not going in the right direction, and that I kind of needed to push myself to come up with other ideas, other ways to approach this client, to help her kind of have it click in that, she did have the skills that she already learned in the previous therapy, that she was able to actually deal with these maladaptive thoughts that she had, and her activated core beliefs about herself in those moments. And so this was obviously a CBT treatment, because I was at Rob de Rubis's lab at the time. And then at some point it did click. And then you saw that her symptoms dropped quite quickly. And so in the end, we were able to finish the treatment successfully. But you can see that there's a big difference between doing a pre-post measurement and doing a session-by-session measurement, not just sort of for me as a therapist, but if you then think about how I might have seen 200 patients, and then my colleagues have seen 200 patients each. Then we have a database of 1,000 patients where we have information on how things are going during the treatment. Now, and also wanted to introduce you to some terminology in this field. So this, for example, this moment where she increased in symptoms is a moment that we call that the patient is not on track. So they're headed in the wrong direction. This is more than just a little bit of fluctuation that we always see, of course. We always have a bit of fluctuation in symptoms. This is clearly a big increase, and that's something we call, in the literature, we call that that the client is not on track. Now, there's other ways of doing like determining when a client is not on track. If we look at this graph, I basically had to decide myself, is the client on track or not on track? Now, this is, of course, a fairly big increase. This is also easy to do, but sometimes with fluctuation, it's a lot harder to determine when do I act? When is it too much? When should I really consider doing something else? And that is where the prediction models come in. So here, this is a graph actually from the next speaker, Jamie Del Cadillo, who will maybe also show this, I don't know. But at least I was also part of the trial that he did in IEPT in the UK. And here you can see that with the fluctuations, some fluctuations are still within the expected range. But some, they cross the failure boundary. This is how they call that. So some crossed the confidence interval that we say, oh, this is what we would expect from a normal course of treatment. And then we see that this is clearly higher than what we would expect. And then so this is then a signal to the therapist, the client is not on track, you should consider acting, doing something differently, discussing this with the client. There's of course a lot of things that you can do, giving a very restricted range of opportunities, but of things that you could do, but there are many more things. Also many more reasons. And then the green line is like the positive boundary. So in this case, if somebody crosses the green line, they're doing much better than expected. And that can actually also work as an indication if you see like multiple sessions below the green line, that maybe it would be time to consider ending the treatment. So that's also sometimes that is also a suggestion that can come out of routine outcome monitoring, like the patient is doing very well, for instance. Okay, so then the more advanced systems, they use these expected recovery curve, sort of systematic way of determining when a patient is not on track. And then when the patient is not on track, an additional instrument is being used, which is called a clinical support tool. Now, what happens is that the client gets not on track, then they automatically get an additional questionnaire that assesses the process of the therapy. So how are things going with the therapeutic alliance? How are things going with social support? You know, if the client is just relying on the therapist as the main sort of emotional support, then it's also, of course, a very fragile system. So then maybe you need to focus on organizing more social support, help the client create a network with friends that they can also rely on a bit for help. And then, of course, motivation and life events. And then here in this, you see that there's different numbers of questions in each category. That's not because there's different numbers of questions, but there's different numbers of questions where the client scores above a certain threshold. So for social support, we do see that this client does not get the emotional help and support that they need from somebody in their family. So the strongly disagree means that they don't get that, and that might be something to address in the therapy, like how they could get that. And then, of course, here there's no red, so there's not overall a lack of social support, but there is a problem in the therapeutic alliance. So, for instance, I felt cared for or respected as a person. This person answers that as neutral. We know that usually patients really value their therapist, so they usually score quite highly. So if this is neutral, that is too low. So that's an indication that there might be something wrong with the therapeutic alliance. And then you can see all the items, and you can see that, you know, this is definitely, I felt that I could trust my therapist completely. The clients slightly agree, but here, my therapist and I seem to work well together to accomplish what I want, slightly disagree. So this is clearly an area that needs to be addressed in the therapy as an alliance rupture kind of situation. And my therapist and I have a similar understanding of my problems, strongly disagree. So there is definitely indication that this client is not feeling like the therapist and they are on the same page. Now, this not on track signaling would, of course, not mean anything if it's just fluctuation and it doesn't have a relationship with the end of the, you know, the final outcome of the treatment. But we do see that it does. So if there's no signal, so the client never crosses that red line or never is flagged as a not on track patient, the chances of having negative outcomes for treatment are about 30%. So if there's one signal, the chance actually increases to 53% that there is going to be a negative outcome of psychotherapy. If there's two signals, that chance actually increases to 70%. So there is a clear relationship between signaling and being not on track and the final outcome, or the chances you have of getting good outcomes at the end of therapy. And this is, of course, important because that means that if you have one signal, and especially if you have two signals or more, that there is really a big chance of the treatment not ending well. And so you really have to then consider doing something differently. Now, there's also been some research where people looked at the patterns, and this is from Michael Lambert's group, and we see basically three clusters. So one is, we see that sometimes there is alliance and motivation problems, and that happens to about 20% of the patients that they analyzed. They have alliance and motivation problems. So then clearly you want to do some alliance rupture repair work in that group, or maybe some motivational interviewing. And alliance and motivation are often quite tightly linked together because, you know, if you're not motivated, it's going to be hard to form a good alliance, and vice versa. If you don't feel like you can trust your therapist, or you are, you know, on the same page and working towards the goals of your treatment, your motivation obviously also is likely to drop. And so this is like a common combination, and that's also what we see in this analysis. Then there is a cluster 2 where there is dealing or coping with life events and social support. And that, of course, also makes sense. About 30% of the patients were having this kind of pattern when they were not on track. Is, of course, if you have a lot of life events that you have trouble coping with, and you have very little social support, then, you know, you're relying completely on the therapist. So that's, as I said earlier, that's a very fragile kind of system. And of course, then, you know, it's much harder for the patients to get through the week for the next, until the next session. And then there's a third cluster, which is about 50%. And that shows a general elevation, which just means that all over the entire questionnaires, there's multiple items that are elevated, but it's not like there's like specifically one problem area that stands out. So there's like multiple ones that are being, so there's problems sort of over the full range. And then there's a lot more things going on. You know, it might be actually also have to do with things like emotion regulation, capacity of the client, and things like that. So these are just some examples of sort of the patterns that we see in this line of research. Now, why do we need feedback in the first place? I'm glad that Thomas already addressed that in his introduction a little bit, but this is, I like this, this comic from a Dutch artist where the client says, I'm not that satisfied with the therapy. And then the therapist says, yes, yeah, I understand. That is part of your psychological problems. And I think everybody who is a therapist will recognize this a little bit because, of course, and it's a very human thing to do. When something negative happens to us, when you're a healthy person, you have a tendency to put the cause outside of yourself because it's better for your own mental health. It's not our fault. It's because the client is very complex and they have trouble like accepting our help or, are not motivated enough, etc. Now, knowing that this is a tendency, I think it's good to remind ourselves of that often, that yes, this is good for our own mental health, but are we then helping the patient in the best way? Or should we maybe also reflect on, okay, some of it might be the patient, but some of it might actually be me, or it might be the interaction that we have, that there's something amiss in sort of how we interact, or are we really on the same page on things? Now, this is a very pivotal study where also from the group from Mike Lambert, where we see why it is so important to get this feedback. So what they did is they asked therapists to rate they predict which of their clients in their caseloads were going to have negative treatment outcomes. And in this case, they defined that as deteriorated cases. So, not everybody improves from therapy. Some people actually worsen. And so they asked, within your caseload, how many people which people do you think are going to be deteriorating? And they knew that 8% overall in their clinic was having an outcome of deterioration. Now, when they were asked to rate their own clients, they actually didn't think that they would deteriorate. There were only 3 therapists who predicted that one of their clients would deteriorate. And they all thought, obviously, that a lot of therapists thought that their clients would not. And so out of those 3, only 1 actually deteriorated. So they were only accurate once, but also 40 patients actually had deteriorated outcomes when they looked at the data at the end of the treatment. They also looked at algorithms for feedback that were like those are like the expected recovery curves, and they could actually predict in 77% of the cases which patients would deteriorate. So without information, so Len Dickman calls this without feedback, therapists are wearing a blindfold while shooting at a target. So we have a tendency to be overly optimistic, and I think that has a function because we want to be, keep the faith for the patient, that there's hope, that there's something we can still do. But at the same time, if we are not measuring our progress, then we are shooting at a blindfold, archery metaphor, we're shooting at a target using a blindfold while we're wearing a blindfold. So we need this information, not, to overcome our own sort of optimism, to overcome our tendency to I'm lost for words, to put the cause of negative things outside of ourselves, and just to get, and it's hard to judge the difference between, small differences. But we saw earlier in the graph that I showed you that if you do have frequent information on the progress, it is easier to see when things are not going in the right direction, and then you can intervene and help these patients in a better way. Okay. I was a bit too quick with my conclusions because there's more research that shows that clinicians tend to have an overestimation also of their own quality. There's research, a couple of studies that have shown that about 2/3 of the clinicians consider themselves to be in the top 75% in their field, which of course is statistically impossible, and 0% believes themselves to be below average for within their profession. The other thing that we often see is that lots of treatments have a rationale that, first the patient needs to get insight into their complaints, and that's why they worsen first. before they get better? Well, I've shown you with the sort of signal outcome relationship. I think that that's not really the case. If they get worse, actually their chances of having treatment failure increases. And so we also know that typically the patients who show a lot of progress in the beginning of the therapy actually have much better chance of ending the treatment in a successful way than patients who do not show such a pattern. So there's also these kind of therapy myths, I think, that are sort of maintaining this idea. Okay, so this is all, I don't know, maybe is this a moment to have like a brief explanatory questions, if there are people who have some sort of questions about this is not clear to me. I'm looking at Thomas for now. Do you think that would be a good idea, or?
Pokud takové otázky jsou, tak prosím zvedněte ruku, dáme vám slovo. Vypadá to, že nejsou. Můžeš pokračovat, Kim.
I'm sorry, I can't now see the translation button. So
okay, it seems that there are no no questions, so you can go on.
Okay, thank you. Okay, so all right, let's talk about the effectiveness of feedback. If we do use feedback, do our outcomes actually get better? Now my slides no longer work. I don't know why. Okay, yes, here we are. Last year I published meta-analysis on the effectiveness of feedback, where we basically looked at almost all of the evidence that is now available, which is 53 different studies from a range of different countries, and there's also many more feedback systems. I've now mainly shown you things from the OQ system, but there are, of course, many other feedback systems. And what we see there is that on average, there is a small effect of feedback on improving outcomes. Of course, the effect is not going to be large. It's a relatively small intervention. So we don't expect, treatments are on average already relatively having decent effect sizes. So we don't expect feedback to then really like double the effect size. It's basically some treatments are going well without feedback. It's mostly the treatments that are maybe not going that well, where we expect effects. So here we also see that in the not on track cases, there's a slightly, not a lot, slightly bigger effect size for helping the patients get better outcomes. But we also see, and this is also important, that there is a reduction in dropout in the feedback group. So if feedback is provided, then dropout is actually going down. And we didn't find effect on treatment duration, but we did see marginal effects on the percentage of deteriorated cases. Now, I should mention that especially those secondary outcome measures were not reported in all the papers, so we also were lacking sometimes a bit of power to look at that. So if we look at the full sample, that means both on-track and not on-track patients, what we did see was that there were a few moderators. So for the full sample, the PCOM system, which is the system with the ORS and the SRS, I don't know if that's available in the Czech Republic, but that's the system from Duncan and Miller, was having a slightly bigger effect than the OQ system, for example, and other instruments were having smaller effects. These are the PCOMs and OQ system are the most commonly used feedback systems worldwide. So there's the most studies on those. And then we see that in the United States, the effect size was a bit bigger than in other countries, which might also have to do with like the care system in the United States and sort of how training is organized compared to mostly European countries that conducted the other studies. We also saw that studies in later years had lower effect sizes. This is commonly seen when a new intervention is out, then usually you find quite big effect sizes, and then it's being replicated in other groups and in other sort of subfields or other patient populations. And then typically the effect size drop a little, and that's also what we found. We also saw that the outcome instrument that was used to evaluate the effect of the treatment influenced the results. So this could be a potential confounder. And in particular, when outcome was measured with the ORS, which is the outcome rating scale from the PCOM system, and not with an independent measure, we saw that the outcomes seem to be a bit inflated. So it looks like the ORS might be overestimating the effect, and which might be an explanation for why the PCOMs had a bit bigger effect size in the full group. If we look at the non-on-track cases, we saw that the feedback type was a significant moderator. If we just provide the raw scores, which is the graph that I showed you from my patient, then we see that the effect in this group is not so big. Now, there's no indication to the therapist when they need to act, so that might be one of the reasons why it's less effective. If expected recovery curves were used just by themselves, not with clinical support tools, then the effect size was a bit bigger. So the effect was just then 0.12, which is still a small effect. And then we see the clinical support tools in combination with the expected recovery curves for this particular group, the non-on-track patients. We see that there is actually a much larger effect size. It's still like a small to medium, still a small effect, but it's definitely bigger than the effect in the other group. So it looks like maybe using these clinical support tools specifically for these non-on-track cases is beneficial compared to with the on-track cases. It doesn't seem like that is doing much, because we of course did the same moderator analysis there as well. If we look at dropout, we see we see here that the PCOMs actually does better than the OQ system a little bit and better than the other instruments. This, I think you can explain for the PCOMs uses both alliance measure each session and the outcome rating scale. And because they have the alliance measure, I think that can help prevent dropout, because each session there's a brief evaluation of the alliance. So I think there might be a potential reason why PCOMs is doing a little bit better in terms of preventing dropout. But of course, we also see that the OQ system also reduces the dropout. And other instruments do as well, but it's like a tiny effect. If we look at countries, again, the United States, we see a larger effect than in other countries. And again, I think that has to do with the way that the care is organized in the United States. A lot of people don't have access to psychotherapy because it's very, it's not reimbursed by insurance companies. And they also have very diverse options for training. So I think, especially compared to some European countries, like for instance, the Netherlands, training is very much regulated by the government. It has like strict criteria. And I think that's less the case in the US. There's more variability in the sort of background that therapists have when they provide psychotherapy. Okay. Then let's look at the cost. So this is coming from Jamie's study, so I hope I'm not like stealing his thunder here. I know that he just joined, so I'm speaking to him directly. But this study showed that this is again from the IAP trial. This was the pilot phase. This was the treatment costs for the control cases on average for an episode of treatment. And here we see the costs for the feedback, the cases where feedback was provided. And so on average, there was a saving of around £100 per case over 249 cases, which was a saving of 24,000 pound, I should say. And so Jamie always jokes that the study paid for itself, because I think he got like a £25,000 grant or something to conduct the study. He might correct me later in the question round. Okay, so now let's look at mediators, potential mediators. So, so when I'm talking about mediators, I mean like for some groups, feedback might work better or less well. And so my research has been focused really on sort of the differences between therapists and how they act on feedback and how they respond to feedback. And so when a client is not on track, we consider this to be negative feedback. What we hope and what we also see in some therapists is that then after the negative feedback, they find a way to do something different and then get back to getting the patient on track. However, some therapists actually show more of a pattern like this, where it's almost like they freeze when they get the negative feedback. They don't know what to do. And then actually the complaints, they stay high or even increase further. So that's another. And of course, here we also have a high risk of dropout in these situations. Now, what therapists have such a pattern, what we see is that it seems to be mostly, but this is still not a lot of research, so it's like a field that is still in development. Therapists who have a low self-efficacy, they tend to have this pattern. And the other group is therapists who have a strong prevention focus. And a prevention focus is that you are focused on preventing failure, opposed to a promotion focus, which is that you are striving to obtain success. So if you have a strong focus on, I don't want to make mistakes, then getting negative feedback, I think, triggers something in the therapist where they feel like I'm not doing well, and maybe trigger some negative thoughts in the therapist that causes them to freeze and not be able to use this moment to then improve the patient. Now, then I want to say something about the quality of treatment versus complexity. This is a very complicated graph from a paper from Rob de Rubis, but what it says here is that basically the complexity of the patient will also determine like how well they will respond to treatment compared to how the quality of treatment is. So if there's no quality of treatment, there are some patients that will still get better, because we also know, of course, waiting list effects and kind of placebo effects. If there's a moderate quality, some patients will still do well, the spontaneous remitters, the easy patient, the blind patient, but the challenging patients will not respond. So if their quality of therapy is good, challenging patients still not responding. If the quality of therapy is excellent, then they start to respond. And there's also, of course, patients who are considered intractable, who you just can't get results with. And then it doesn't matter how high the quality of the treatment is because they're not going to improve. Just this is to show the general idea that the complexity of the patient may actually interact with the quality of the treatment. Now, why do I say this in the context of feedback? Because we looked at the interaction between the complexity of the case and the effectiveness of the feedback. And so we measured complexity on a scale where we combined a couple of from our own experience and from the literature, risk factors for negative outcomes. So we looked at marital status, if somebody was widowed or divorced, had no indication or only primary school, was unemployed, on long-term sick leave or disabled, and had comorbid axis 1 or axis 2 disorders. It was still in the DSM-4 time, and an ethnic minority of non-Western descent. So these are all known risk factors for having negative outcomes. And then we hypothesized, also in part based on Jamie's work, that having one risk factor might be one thing, but if you have multiple risk factors, that the chances actually increase that you will get negative outcomes. So based on this complexity score, we then diverted the patients into a low complexity, medium complexity, and high complexity group. And what we saw was that in the low complexity group, there was no effect on feedback. So think about sort of the previous graph where I showed you that with easy patients, actually the quality of therapy doesn't need to be that well. Everybody's going to actually respond. So that's similar to what we saw. In the medium group, we saw a small effect it was doing something, but not a whole lot. Like it was a small effect. And then the high complexity group, and this is a complicated graph, but I'll walk you through it. We saw that for the on-track group, so we had a group where there was no feedback, we had a group where there was just simple feedback, the raw feedback, the graph that I show of my own patients. And we had a CST feedback with expected recovery curves and with the clinical support tools. Now, the on-track group are like the purple, the yellow, and the red dots. So this one, I don't know if you see the cursor move, but those three lines, there was no difference between those groups. So for on-track patients, it didn't matter if feedback was provided or not. They all, on average, improved over time. Now, if we look at the non-on-track group, let's first look at the blue dots. The blue dotted line shows that there's a slight increase, and there's definitely, well, it's more or less stable, but there's no real benefit here. They're really not improving in therapy if they are in the non-on-track group. Now, if we look at the simple feedback, the ROM feedback without the expected recovery curves, the raw feedback, we see the green line that actually is a similar pattern, although they have like initially a bit of a rise. They start a bit higher, but there's no significant difference between these two because it's mostly an intercept effect. They are higher than the no feedback group. Then if we look at the CST feedback, which is in the orange, but it's actually beige, more beige in the graph. It starts here and then goes down, 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 and actually has a similar effect. They have similar outcomes as the on-track group. So this is a big effect. In these high complexity patients, having those clinical support tools are especially helpful for this group. So this, I think, gives us an idea that with these more complex patients, the therapists, they need more help. And the clinical support tools, they provide them with ideas. Oh, there might be something with the alliance. There might be a motivational problem. We may have to give them organize better social support to them, or we need to teach them coping skills, how to deal with negative life events. And you see that the effect of the treatment was much better. At same level, actually, as the on-track patients. So some ideas of why feedback might actually work. One of them is that actually it might fill the blind spot. So here we see the time until a topic that's important to the patient is being discussed. In the feedback group, you see a no feedback is the green line. You see that this is normally the time it takes before it gets discussed. In the feedback group, you see that the slope is steeper. And so the topics that are important to the patients are discussed earlier. So maybe the feedback gives us information that then prompts the therapist to bring it in, or prompts the patient to bring it into the treatment sooner. So that might be one thing. The other thing is that it may change clinicians' expectations. Remember that we talked about the overestimation that clinicians had. In this study, we asked therapists to also to estimate whether their patients would end the treatment in recovery or not. And what we saw in the no feedback group was at 5 sessions, they thought 65% of their patients would recover, and they thought the same, about the same in session 10. But then when we looked at the actual outcomes, there were only 37% of patients who recovered. Then if we look at the raw feedback again, so without the bells and whistles, we saw something similar, but actually here the treatment outcomes were better. So the difference between what the therapist thought and the actual outcome is smaller, but that is just because the feedback improved the outcomes. Then if we look at the CST feedback group, we see that after 5 sessions, the therapists still think a fair amount of their patients will recover, but after 10, they actually have adjusted their expectation. And then we see that they're actually very close to the actual outcome. And this we also see over time. We see that in the control group, there's not a lot of adjustment in the expectation of therapists on how much their client will change. If we look at the ROM feedback, so it's the raw feedback, we see that there is a bit of change. And if we look at the CXT feedback, we see that there's more change. So the therapists become more realistic about what is likely going to happen as a result of the treatment. Final slide is that the overall effect of feedback is small, but it's quite robust. We have a large sample in the meta-analysis, and it showed that it was quite robust. There is a positive effect on dropout. We also see that maybe it's good to tailor feedback to the treatment setting, and that some groups may benefit more from different systems. Like it seems like the on-track patients do a little bit better with PCOMs, and the not on-track patients do better with the CSTs. And that also the therapist characteristics may influence the effectiveness. I see that I stopped like my last sentence, and I don't remember what I meant to say there, but in any way, I think the conclusion stands that the therapist characteristics may still there, and we have some ideas about what is going on, why feedback enhances the treatment, but there's also still things we don't know. And this is a good moment, I think, to end.